Okay. Good afternoon, good morning, or good evening, wherever you are. So my name is Ines Raimundo. I will be chairing this session. It is really such a great pleasure to be in this platform and sharing what we are going to discuss. So our session is it's about health issues, what is going in our cities. That's really interesting because here we have Africa representation, also we have Asia and Latin America. This is really amazing. So according to our schedule, we're supposed to have 3 presenters. We have Vitor from Colombia. We have Abimbola from Nigeria, and we also have Xiao. Xiao, it looks like Xiao. We have that word Xiao and Chao. Xiao and Chao means bye.
Hi, you can call me Xiao. Okay. Thank you very much.
Yeah, you're welcome. So now, okay, we have a plenty of time, 40 minutes, and I think in this platform we only have how many they are here. The participants, I think, are except the technician, we have 5. So we will start from Vitor. So Vitor, according to what I read here, your paper is a joint paper, so that you will, there are other contributors from Switzerland, and we are also learned that you are a PhD student in Switzerland. So your topic is, as it written here, is using an open access data to explore the relationship between urban morphology and diarrheal diseases in Cote d'Ivoire, Abidjan in Africa. So please, Vito, can you take the floor?
Thank you, Ines. It's a great pleasure to be here with you all. As you mentioned, this paper is the work that is being presented here today is a collaboration with colleagues from the Swiss TPH, the Swiss Federal Institute of Technology, and the Swiss Research Center in Cote d'Ivoire. What I'm presenting today is a very early stage of a paper that we are working together with these colleagues. So Dr. Jörg Utzinger, Brahma Kone, and Jérôme Chenal. And the main scope of this work is to explore whether landscape metrics can be used. Sorry. Sorry, there was a problem with another device. That, so as I was saying, this is a project that aims to explore spatial predictors of diarrhea. And now I have a question because I sent a pre-recorded presentation. Are we using that, or should I open a PowerPoint and do live?
Yeah, it's up to you. I don't know which one do you prefer. If it's a presentation, like
one would be better if we can use.
Okay.
Pre-recording presentation. I will share.
Okay. Thank you, Bicha.
Hello. So is everybody listening to me? Can you hear me?
Yes, yes.
Okay. So I will share Mr. Victor pre-recorded.
Yeah. Okay.
Hi everyone, my name is Vitor Pessoa Colombo and I am an architect and PhD candidate at the Swiss Federal Institute of Technology in Lausanne. I will briefly present you an ongoing investigation that is being conducted with partners from the Swiss Tropical and Public Health Institute and the Swiss Center for Scientific Research in Cote d'Ivoire. So this investigation aims to explore spatial predictors of diarrhea in Cote d'Ivoire using strictly open access data. This presentation is structured as follows. I will start by presenting the research gap, then I'll introduce the geographic focus of the study, then we'll go through the materials and methods used, and finally I will discuss the preliminary results of the study. Many studies have shown the impacts that water, sanitation, and socioeconomic indicators have on hygiene, and therefore on the risk of diarrhea. However, little is known about eventual connections between settlement morphology and diarrhea. In fact, while different studies show how urban morphology can be related to predictors of diarrhea, there is still a lack of research on whether landscape metrics and urban form could consist per se in predictors of diarrhea. We address this research gap in the context of sub-Saharan Africa, where diarrheal diseases still inflict a very high burden on the population. More specifically, the study focuses on Cote d'Ivoire, a West African country where diarrhea is among the top 10 causes of death. Now, let me introduce the materials used in this study. As mentioned previously, this study was strictly based on open access data. The Institute of Health Metrics and Evaluation provides geo-referenced data on several health conditions, as well as on education, water, sanitation, and hygiene services. The data consists in rasters with a resolution of 5 kilometers, containing estimates calculated from different surveys. The Institute provides yearly estimates starting at the year 2000. For this cross-sectional analysis, we chose the year of 2016 because we could also obtain settlement data for the same year. What you're seeing now on the slide is a map showing the spatial distribution of the prevalence of diarrhea according to the Institute, and it is precisely the prevalence of diarrhea that is the outcome of interest in the study. The settlement data consists of 3 layers. The first one is land cover, provided by the Copernicus Land Monitoring Service that systematically produces global maps of land cover. The Copernicus service releases this data in a raster format at a resolution of 100 meters. Land cover is, of course, classified in several categories. In this study, the ones that interest us are those directly related to human occupation, like built-up areas or croplands. This slide here shows a close-up on Abidjan to illustrate the data. The second layer of settlement data is demographic density. In this regard, the World Pop project provides yearly estimates of population counts at a resolution of 100 meters. These estimates are based on local surveys and remote sensing of buildings. The results are adjusted to match the United Nations population estimates. Here again, the slide shows a close-up on Abidjan to illustrate the data. As one may see, these estimates are impacted by administrative boundaries, which is a limitation in terms of accuracy in the case of this study. The third and last layer of settlement data are the night lights captured by NASA's Earth Observatory. The Earth Observatory provides images of Earth at night at a resolution of 500 meters for the year of 2016. These images contain information on the intensity of night illumination, which suggests human occupation and especially the presence of infrastructures. This slide shows the data for Abidjan adapted from a grayscale. The three layers of settlement data were combined in order to characterize built-up areas. Night illumination and demographic density were merged within the boundaries of built-up areas. This allowed to reclassify built-up areas into three distinct types: precarious areas, regular areas, and well-structured areas. Areas with high levels of illumination but low density were considered well-structured. Conversely, areas with high density levels but poor illumination were considered as precarious areas. This slide shows the results of this step in the area of Abidjan. Once the settlement data was all set, we aggregated morphological indicators by reusing the grid given by the health data, that is, the 5 kilometers pixels of the raster provided by the Institute of Health Metrics and Evaluation. These 5 kilometers pixels, shown here with red lines, were therefore the spatial aggregation units. In this way, each 5 kilometers pixel contained information on the proportion, edge, and fractal dimension of all types of land cover classes, together with access to wash services, education level, and prevalence of diarrhea. With this resulting dataset, it was possible to obtain correlation coefficients between the prevalence of diarrhea and multiple indicators related to landscape metrics and urban morphology. Before running the correlations tests, we established a selection criteria to filter the observations, that is, the 5 kilometers pixels. We only included in the analysis pixels with at least 1 hectare of built-up area, that is, the minimum area detected by the Copernicus service dataset. In this way, we only included pixels containing human settlements. In total, this corresponds to more than 8,000 observations, or pixels. In addition, each 5 kilometer pixel was classified according to the level of education and the level of access to improved water and sanitation. Because socioeconomic conditions and access to water and sanitation impact the risk of diarrhea, it was important to balance the analysis through group matching. This was done in order to mitigate the statistical impact of these confounders. In this way, the correlations were calculated amongst pixels belonging to the same group with similar levels of education, water, and sanitation. As this diagram shows, we established 9 groups based on a matrix of low, medium, and high levels of education and wash services. This table shows the Spearman correlation coefficients between the prevalence of diarrhea and 2 variables: the proportion of precarious areas and the proportion of croplands. Because these variables do not present a normal distribution, we opted for Spearman's correlation coefficient instead of Pearson's. The correlation coefficients are shown by the control group, listed here on the first column on the left. As we can see, the correlations of both variables are impacted by the level of education and the level of urbanization. Indeed, correlations got systematically stronger with lower levels of education. Also, especially in the case of precarious areas, these correlation coefficients got stronger as the proportion of built-up areas got higher. The strongest correlations are highlighted here in a darker tone of red. Globally, the proportion of croplands seemed to have a negative effect on diarrhea, while the proportion of precarious areas are correlated to a higher prevalence of diarrhea. The impact of both areas seems to be more important in pixels with high access to water and sanitation, but low access to education. These results suggest that water and sanitation alone are not sufficient to prevent diarrheal diseases, and land use should be included in the list of preventive measures. Of course, there are limitations to the study. The coarse geographic scale reduces the accuracy of the ecological analysis, and health data consists of estimates, not actual epidemiological surveillance data. However, these limitations are compensated by the geographic extent of the study and the fact that it is replicable to anywhere in the Global South, as it is strictly based on open access data. Previous research on environmental risk factors for diarrheal diseases have focused on the impacts of water and sanitation infrastructures or on the impacts of social environment. As we have shown with this study, land use and morphological indicators should also be investigated as potential risk factors for diarrhea. If space is a social product and thus reflects socioeconomic and living conditions that are risk factors for several diseases, it should be looked at as a primary variable of exposure in health studies. Thank you very much for your attention, and I look forward to your comments and inputs.
Wow. Thank you very much, Vitor, for your presentation. In fact, what sparked my attention in your presentation, it is really about how easily you were able to use data. Normally here in Africa, we usually say that we can't do any analysis because there is no data. But you use this big data from all these international agencies, which is really good. It's really a good example for academia. It's really a good example for young scholars because we spend time saying that there is no data for that. And also that the second thing that sparked my attention is this ability that you have to use these satellite images, use special data to establish a correlation about diarrhea in a specific or particular city, which is this Cote d'Ivoire. I'm also really impressed about no, it's not really in terms of impression that, but I wonder, it's one of the first questions that I will have later on we can discuss. Have you looked particularly to the age population? Because when you talk about diarrhea, who are mostly affected are children. So I don't know if your data is specific to children or is the data that is covered all age. So it's something that we can discuss later. So for a while, thank you. So let's move to is Xiao Xiao. No, is yeah. Who is the second one? Is yeah. Okay, the second one is Xiao Xiao, please. Hello, Xiao Xiao.
Hello.
Yeah, you're welcome. I don't know how will you present.
Yes, she will present.
Yeah.
I have a recording.
Yeah.
Okay, good. Thank you.
Sorry for that.
Yeah.
Sorry. Okay.
Good morning. I am Xiao Xiao, a PhD student from the University of Chinese Academy of Sciences. Today, I'm so excited to share our latest study uncovering the spatial temporal pattern and geographical equity of pharmacies in Chinese cities from 2008 to 2018. Now, let's get started. My presentation will cover the following aspects, respectively: introduction, method, results, discussion, and conclusion. Firstly, let's move to the introduction part. As we know, the health service facility is a crucial infrastructure for people's health, and the pharmacies are becoming the most fundamental critical service unit of the health service system. At the same time, urbanization is one of the global trends of our time. China's urban population rised continuously. In the process of urbanization, unchecked and unplanned urban inequality are universal concerns, both within cities and across territories. Reduced spatial inequality has been one of the reinforcing goals of UN Habitat's strategic plan for the period 2020 to 2023. The distribution and availability of premises were recognized as an important element to reduce spatial inequality, generate local economic activities, and promote social cohesion. Appropriate spatial allocation of premises is a significant contributor to sustainable development and new urban agenda. Currently, studies on the spatial temporal pattern of premises still face some challenges. For example, most current studies use a single urban or rural area as a case, mainly relying on small-scale field data or statistic data. Therefore, seeking new data results to enhance cognition of the spatial temporal pattern of premises in large spaces or across spaces is a significant challenge. Besides, most current studies use supply and demand ratio between resources numbers and population that does not involve spatial concepts such as distance. Therefore, the scientific questions we have addressed are as follows. At first, how to develop a new data-driven methodology for illustrating the distribution of healthcare resources. The second is how to quantitatively review geographical equity of Chinese pharmacies. Next, I'm going to share the data and method part with you. Focusing on the above scientific questions, we designed our technical route. We firstly established a premises POI database based on POI date and auxiliary date. Then determined the indexes, including number of pharmacies, NPP, and PDI. On this basis, we use growth rate, average value, standard deviation, as well as hotspot analysis to complete the experiments. Our results are about spatial pattern and changing characteristics, assessment of the availability, and spatial disparity and distribution. The last part is results discussion, including of comparison with WHO's recommendations, comparison of indexes, and suggestions. For the data, we obtain the points of interest of premises from the Gaode map platform. The properties information of each POI include name, type, and location. Finally, we obtained more than 60,000 premises POIs in 2008 and more than 400,000 premises POIs in 2018. Except for the premises POIs, the auxiliary data such as population, land area, and GDP were obtained from the China Economic and Social Big Data Research Platform, or China Urban Statistical Yearbooks. The city-level boundary data was downloaded from the internet too. Based on the above data, we measure the premises equity by two indicators. The NPP reflects the resource availability, and the PDI reflects the balanced allocation of resources in terms of population and geographical area. Then we map the cold spot areas and hotspot areas of the premises to analyze the aggregation of premises allocation balance. Next, I'd like to bring the results from the experiments. The first result is about spatial pattern and changing characteristics. The average annual premises growth rate from 2008 to 2018 was 20% in China. In contrast, the average annual population growth rate and GDP growth rate were 5% and 11%. It is very obvious that the number of pharmacies differed significantly on both sides of the Huhuanyong line. The next result is about assessment of the availability. The NPP of Chinese pharmacies increased from 0.5 to 3, and the high-value area shifted from economically developed cities to less developed cities, while low-value area covers the 8 minority autonomous regions in Western China. Now, let's look at pharmacies availability in countries all over the world. The WHO once recommended an NPP of 1.4322. The existing studies shown that in European countries, the NPP is 0.5 in Denmark to 7.8 in Greece. And South Africa advocated that NPP should be more than 1. In New Zealand, the NPP is 2.2, and in Malaysia, the NPP is 0.1, while in China, the NPP is 3 in 2018. We also found that the Pharmacy Density Index annual growth rate is 19%, and the urban PDI differed significantly on both sides of the Huhuanyong line too. Comparing to NPP, the PDI helps to correctly evaluate the allocation of pharmacies condition in sparsely populated areas. The last result is about spatial disparity and distribution. In 2018, the city-level PDI showed a clustering pattern. There were 42 significant hotspot cities clustering in the Pearl River Delta region, while 22 significant cold spot cities distributed in the middle and upper Yellow River basins. Okay, let's move to the discussion part. Firstly, as a new type of emerging geospatial big data, POI provided accurate and real-time support for the study of pharmacy distribution. It is shown that the Pharmacy Density Index can reasonably measure the geographical equity of pharmacy allocation, as it considers both population and the land area. Based on our study, we also suggest that the policymakers should implement differentiated pharmacy allocation strategies according to different regions. In particular, I would like to emphasize the conclusion of our paper. In conclusion, our study developed a methodology of illustrating spatial temporal pattern of healthcare resources, and in terms of geographical equity of pharmacies in China, the municipal pharmacies allocation showed a distribution trend of east high, west low with Huhuanyong line as a boundary. There are high-value gathering areas in the Pearl River Delta area in China. Last but not least, we argue that POI data should be combined with survey data of pharmacy type and service quality to deeply discuss the rationality of pharmacy layout. Okay, that's all for my presentation. Thank you all for your time. The comments will be welcome.
Okay. Thank you. Thank you very much, Xiao Xiao. I was really pleased to listen your recorded presentation. And like what I said to Vito, the commonality of both studies, you use statistical models to explain a specific issue or specific problem that you are studying, which is really, really fascinating, and it's really good. So, Xiao, I want you to think before the next presenter about these challenges that I'm putting to you. I've learned that China is known by natural medicine, which includes the therapy based on plants and anointment, which is really very popular. So my question to you is, in your study, what kind of pharmacy are you analyzing? Because I also heard that you presented, we were talking about the drug stores, which is more than a pharmacy. But also when you use this concept, the word of pharmacy, I'm thinking of traditional pharmacies that the Western African, Western European countries use, or even American countries they use. So which kind of pharmacy are you talking about, considering that in your country, what I know, sorry if I'm wrong, is you use a lot on natural medicine. Here in my country, in the specific city where I am, they quite have some clinics that are owned by Chinese. So they are popular because they use this natural medicine. And another question that I want, if you could think about, is okay, we know that China is the most populated country in the world. Okay, so how do you consider that special distribution of pharmacy equity, if there is any equity in terms of the distribution of pharmacy, considering if trying to relate population density and the pharmacy existing in cities, even in rural areas. So this is what I wanted, if you could think or elaborate more. If you are not able, okay, that's fine, but it's part of my curiosity. So then let's move to Dr. Abimbola. Sorry if I mispronounce your name. Yeah, Dr.
Perfectly.
Okay. Yeah.
You pronounce it perfectly.
Okay, so please, you understood that it will be a live presentation, so please take the floor. Thank you.
Thank you so much.
Okay, thanks for that. And for your first question.
No, sorry.
Are you ready?
Later on, after Dr. Abimbol, okay?
Okay, okay.
Yeah,
Okay,
yeah,
sorry.
okay.
Okay.
Yeah.
I want to ask to Mr. Abimbola if.
Can they share the slide?
Okay.
Yes. Yeah, good afternoon. The panel chair and the participants, co-participants, presenters. My topic is, or title is, Appraising the Impact of COVID-19 Pandemic and Climate Change on Urban Residents in Lagos, Nigeria, which is a country that is located along the tropics. The thematic area is within management of COVID-19, pandemic, and climate change in cities. Yeah. Next slide, please. The paper is divided into 7 sections. I have the introduction, the statement, aim and objective, conceptual issues, methodology, data presentation and finding, conclusion and recommendation. Actually, I will employ the participants to look out for the statement of problem, conceptual issues, then the methodology, and then what I found out in the analysis, and then conclusion and recommendation. By way of introduction, Nigeria is an urbanizing country, and more emphasis, people, particularly the youth, are moving from the rural area to the urban area. And Nigeria is part of the countries like India and China that are really adding much population to the world population between 2018 and 2050. Indeed, Nigeria continue to rapidly urbanize. And the problem is that there is a disconnection between the rate of urbanization and then the rate of urban development. And this has led to what the statement of problem that we are looking at. There's a mismatch between rate of population and industrialization, economic growth. So what we have in a way is like urbanization of poverty, which has really resulted in the type of cities that we have in the country, particularly cities like Lagos and other big cities. What we have, because of the inadequacy of preparation for the consequences of urbanization, what we have that are staring us in the face in most of the cities that are rapidly urbanizing include blighted areas, urban poverty, sanitation problem, lack of sanitation, and then lack of open space and overcrowding. So this has led us to defining our aim. The aim is to actually appraise this is the bad period in the global, globally, because of the pandemic, the scourge that really ravaged the globe, since last year, coupled with climate change, with particular reference to erosion. With particular reference to urban flooding, which is an indicator of climate change. Now, what we have today is that Lagos has really been under the threat of urban flooding. I look at the figure for the past 10 years, and from 2010 to 2020, I found out that 2011 and 2012 were really bad years in the country, where you had there were so many people dying as a result of urban flooding, coupled with destruction of properties. So in the same way, because of overcrowding and lack of adequate infrastructure, you find out that the study area, which is Mushin, one of the most densely populated local government in Lagos, with a particular that are manifesting this problem, challenge of urban flooding, as well as spread of COVID-19. And the reason being that it's an area that is deficit in terms of adequate infrastructural facilities, and the ones that are available are even under pressure. So this has really led to problems that are still battling with. Unfortunately, out of the 36 states that we have in the country, Lagos is the worst hit in terms of COVID-19 experience. Nevertheless, what the study went about to do was to examine aspects of urban infrastructure, housing quality, as well as environmental condition, to see how improvement in this area can actually lead to creation of resilient city, using that study area as a case study. So I found out that a study, the method of data collection was based on questionnaire administration, whereby about 320 citizens were administered with. Yeah.
Can you tell me when I
should change the slide?
Yes.
Yes, I'm already ahead of the. I've spoken about the statement of a problem that urbanization of poverty resulted from the mismatch between migration rate and industrialization or economic growth, and this has led to problems. Urban problems, including shortage of housing quality, overcrowding environment, lack of green space, inadequate water supplies. All this increased vulnerability to disaster, particularly COVID-19, that is the bone of contention. Next slide, please. Yes, I said that the aim of the study is just to appraise the impact of this disaster, these shocks and stresses, climate change, and COVID-19 on the well-being of the resident, bearing in mind that these people are living in a crowded neighborhood that is deficit in terms of, that is deficient in terms of infrastructural facilities. So using the factors of housing quality and environmental condition. And now the objectives are clearly stated. Know the impact, look at the coping mechanism, and then the policy implications that can help to create a resilient, that can be adopted to create a model of a resilient city. Next slide, please. Yeah, conceptual issue, this is very germane to what we are talking about, housing quality, well-being, and resilient city. We believe that housing quality has to do with looking at the physical condition of the homes, as well as physical environment where the dwelling units are located. And it's all about accessibility to basic infrastructural facilities that will make people to be healthy, that will make the city to be livable, that will make the housing dwelling unit to be habitable. And once these are guaranteed, then well-being of the citizen is enhanced. So, so what we are talking about is in a situation where there is inadequacy in housing quality, improvement in housing quality will usually target enhancing the resilience of the city to disaster. Next slide, please. Yeah, city's resilience, I want to concentrate on this, has to do with ability of a city to absorb, to recover and prepare for future shocks. It's all about ability of city and inhabitant to be able to maintain continuity, through all shocks and stresses, which is the focus of SDG 11, talking about a city that is sustainable, city that is livable, city that is resilient, city that is healthy and safe. So resilient cities continue to function in the face of flooding and pandemic. This is what we are trying to, a model of what we are trying to create in the study, using the study area as a model that other cities can fit. Quickly, let's go to the next slide. Yeah, that's the study area. One thing that we need to know is that the density, if you look at the density of this study area, is 50,000 per square kilometer, whereas the average density for other neighborhoods in Lagos is about 20,000 kilometers. So that means having that crowded environment, lacking in infrastructure, has actually compromised the health of the people, has actually made the area to be vulnerable to this pandemic, disaster in terms of urban flooding and pandemic. Next slide, please. Yeah, these are the history of, I told us that 2020 and 2011 were the most devastating in terms of history of flooding in Lagos, and the causes are simply both man-made and natural disaster. The climate change aggravated by human activities. Next slide, please.
We're running out of the time. Sorry.
Sorry?
We're running out. Yeah.
Okay. Let's go to the recommendation, because the findings are there. People are suffering. Their businesses have been affected. The control measures that were put in place were ineffective. And so what do we have to do? What we need to do is in the, can you go to the conclusion and recommendation, please? Conclusion and recommendation, what I have there is that the COVID-19 pandemic and then the urban flood is ravaged everywhere in the country, particularly in Lagos City, and we have found out that is the problem hinge on overcrowdedness and inadequacy of facilities. So what do we, and infrastructure facilities. So what do we have to do? What we need to do as a policy guide is to embrace good urban governance. Good urban governance means let's have inclusionary planning, where everybody, the government, the private sector, the citizen are brought together to think out of the box, how they can improve the welfare of the people. They should have access to basic needs of life, and then the government should ensure, coupled with the people, preparation towards the future occurrence. The second one has to do with urban regeneration. We need it. Retrofitting has to be put in place. We have to embrace the concept of one-stop shop, whereby government at various levels are given responsibilities to provide all that will make life meaningful for the people. In this way, what we are trying to do is we are seeing housing as a insurance, a home as health insurance. Again, we are seeing houses as a normal situation, whereby people will stay at home and you have to put the facilities, water, light, electricity for them to live comfortably. So in case of any future lockdown, again, you can embrace the policy of health vis-a-vis urban planning. You have to have health care facilities well equipped at various territorial planning of the urban area. Then you must have embrace the concept of greening the environment, embrace parks, embrace gardening, and so on and so forth, to control the menace of urban flooding at landscaping. And then finally, spatial planning. Spatial planning, you have to put deliberately mixed uses, compact urban form, whereby you put uses together in an equitable way, so that people they know that the reason why you are doing that is to break the barrier of social distancing. You don't want to make people to come together, but if these things are provided at various levels, the tendency is that it will reduce the need for people to go out outside their territory. So this is all that I have to say. I want to thank you for listening, and thank you so much.
Thank you, but I really appreciate your presentation. And I have just one question to you. So I'll give for each of you 2 minutes to respond. So for you, Abimbola, it's you gave us a lot, so many of recommendations regarding with your city. So my question is, how easy or how difficult it is to implement what we are saying for what we are suggesting in your study? So, Victor, your question is about the age, the diarrhea age rates. How do you think of that?
Thank you for your question. It totally makes sense. As you said, children are usually more exposed, more vulnerable to this type of disease. And in fact, the data that we use is a prevalence of diarrhea in under 5. I'm sorry I didn't specify this in the presentation, but the data that the Institute for Health Metrics from the University of Washington, the data that they make available is diarrhea for under 5, indeed. And thanks for your comments regarding the effort on the data that is available in African countries, because indeed, I totally agree with you. I think we underestimate a bit what can be done in terms of analysis, especially spatial analysis. And there is a lot that we can do with the remote sensing, and also a lot that we can do by reusing data that is available from open access studies. And I think this is a recent trend, right, in science to make science more open, to share the results, share the raw data. And I think this is really important that as researchers, we work together and not in competition, right? So that we share our results as well, not only in text, but also in terms of raster data, vector data, etc. So, I think you're muted, Ines. We cannot hear you, Ines.
Abimbola,
Yes, thank you.
we are taking a picture. We are taking
Sorry?
a picture now. We are taking a picture.
Okay, thank you so much. Yes, thank you for the question.
Wait, Abimbola, wait, we're taking a picture. Hello?
Hello? What did you say?
We are taking a picture.
Picture.
Photography.
Okay, okay, okay.
Is it done? Hello, let us continue. Xiao.
Sorry.
Are we done?
I want to ask to Irene Lin to put her camera on.
Yes, we're all of us, we have our cameras on.
Okay.
Okay, then. Is it okay? We still have some people to respond our questions.
Yes, it's okay. Thank you.
Okay, thank you. So Xiao, please, can you answer us just 1 minute, please? Xiao?
Of
Yes.
course. Okay.
What kind of pharmacies are we talking about?
For your questions, for your first question, thank you for your question. And for your first question, you mentioned the categories of the pharmacies. Of course, it is a very important. It is very good question, and because our data is limited, the POI data can only show all the kinds of pharmacies. Even though the categories of pharmacies is very important factors that, but our data, how can I say, in the our main aim is we aim at the spatial accessibility of different maybe of all kinds of pharmacies, therefore the spatial accessibility of different types of pharmacies should be further explored in the future by combining statistical survey data. In addition, POI data cannot provide information on drug supply, licensed pharmacy staffing, pharmacy size, and average diary prescription quantity, which restricted the assessment of a pharmacy service quality. And in the future, and POI data and field survey data will be integrated to establish a collaborative, decentralized data collection method and a multi-level, cross-regional and cross-departmental shared database, so as to provide basic data for the global health service capacity monitoring. So it's quite okay.
Okay. Okay. Thank you. I'll come back to you later. Let us hear Bimbola.
Yes, thank you. Thank you for the question. The question was about the implementation of these recommendations. They look massive, but they are implementable, they are doable. And the simple way by which already government is aware of that, and I think they are doing their best, is just the political will. The resources are there to mobilize, to spend. I mean, for all these, the things I would recommend is that we should go back to Decree 88 of 1992, which actually made aspect of planning, human settlement, livability and functionality, a three-tier government responsibility, federal, state, and local, so that if you can embrace that policy, if you can go back to embrace it, and decentralization, once we decentralize, we will get it right to be able to get all these recommendations implemented and achievable. They are quite achievable once the political will is there towards decentralization and autonomy to each level of the government, tier of government. I think that is just it.
Okay, thank you, Bimbola. In fact, I was curious about the willingness of stakeholders to accept this kind of suggestions, because as much what I know about sub-Saharan Africa is we have done quite a lot of studies and we have done a lot of recommendations, but there is a challenges to implement these recommendations. So that's why I was asking you that question. But anyway, thank you for that. Xiao, there is a question for you. Have you read it on the chat? Yeah.
I have a question later, Mr. Waiter, and I think your research is very interesting. And I have a question about your data. You use the multi-source of data. You use the land use data and night light data and any other and so on. I want to ask a question. First question is why you studied the relationship between the urban morphology and the diarrheal disease. And I saw you use the urban density as a index, as an index. So why you use this urban density to how to say, to express to present the urban morphology. I don't know.
Yeah.
Okay.
That question is for you, that Bimbola, because you use it, density, population density, and morphology to explain your problem. So she wanted to know why was that? Why did you use population density?
Was it to me or to Abimbola, the question?
I think it's to Abimbola. No?
Okay. So thanks for your question, Xiao. Start with the conceptual framework. Why trying to work on correlations between landscape metrics, urban morphology, and diarrhea? Precisely because this has not been explored a lot before. There are a lot of studies relating urban morphology, so spatial indicators and socioeconomic indicators. There are a lot of studies relating socioeconomic indicators and diarrhea. However, there's not yet a lot of studies trying to explore whether spatial indicators per se can be directly related to diarrhea. And that's what we are trying to do here. So why is density amongst the indicators that we use? It's because we wanted to be able to characterize built up areas. We can obtain data saying the urban perimeter, but what is the quality of urbanization within this urban perimeter? I wanted to be able to disaggregate this data. So this is why I crossed illumination as a proxy of presence of infrastructures and density to characterize the built up areas, the urban areas, into what I call precarious areas, regular areas, and well-structured areas. We assumed that areas that are very dense should have a high index of illumination, because if there's a lot of people, you assume there is light there. However, in areas where you have a lot of people but very little light, this means that there is a incoherence between infrastructures that are present and the number of people that are there. So we work on this hypothesis that areas poorly illuminated and very dense can be characterized as underserviced areas. We use this specific data because it is available for the whole African continent. So we wanted to use data that is really available for a large scale analysis and that is replicable elsewhere. So this is really a study that explored two things: what we can do with strictly open access data and what we can do in order to relate spatial indicators, landscape metrics, and the risk of diarrhea. Is it clear?
Okay, thank you. Okay, thank you very much.
Okay, so Xiao, could you please go to the chat?
What? Sorry? Oh.
Bimbola put a question to you on chat. Can you read it? No? You didn't get it? Okay, I will copy to you. Okay. Yeah, I just copied to you. Copy and paste.
maybe now the answer, my answer is maybe the pharmacies. Pharmacies are the basic element of the urban health system. Maybe the spatial distribution of pharmacies and the service capacity have been one of the core topics of research in disciplines such as health geography and public health. So I use the pharmacies. We use pharmacies as but the hospitals and the clinics, how to say, maybe we use the pharmacies as an example instead of the hospitals and the clinics. Yeah, most of the existing studies focused on the pharmacies, especially in the South Africa cities and the other countries all over the world. And so we want to use the pharmacies as a case, and to study the accessibility of the basic health elements of cities. Of course, the hospitals and the clinics are also very important in cities. And so in our future research, we will focus on both pharmacies, hospitals, and even and especially as well as the beds to study the urban health issues.
Yeah. Okay. I think
Thank you.
is happy. If we had more time, maybe we could continue discussing. But let me wrap up what we have been.
Please, Chair, please, I have a question for Victor. Please.
Oh, okay.
Yeah, Victor, please, two things caught my attention during your presentation. One, there was a slide that you showed showing the prevalence of diarrhea. And I found out that the northern part of the slide has less prevalence. So I don't know the reason for that. Maybe you have information. Then secondly, you said towards the conclusion that it's not only water and sanitation that should be considered when diarrhea stuff is being talked about, but land use. I was now imagining, I was thinking aloud, what if you pick two land uses now? For example, industrial, or I don't know whether you have particular land uses in mind, but as an urban planner, I was just looking at how will industrial land use aggravate or minimize prevalence of diarrhea as against educational land use.
Thank you for questions, Bimbola. So starting with the remark on the low prevalence of diarrhea in the north of Cote d'Ivoire, discussing with my colleague at the Swiss Center for Research in Cote d'Ivoire, what he thought is that these are the consequences of wash projects around the city of Korogo, which is called the North Capital in Cote d'Ivoire. So in the last decade, there have been quite a few projects to improve sanitation and water services in that region. Well, this is data for 1 year, which is a limitation for the study. But what we see is that we could attribute these lower prevalence of diarrhea to these infrastructural efforts that have been done in the last decade. Now, what I meant with land use is that in this study that we did, crossing landscape metrics and diarrhea, we quite surprisingly, we found a very strong negative correlation between agriculture, croplands, and the prevalence of diarrhea. And by the way, also in that northern area around Korogo, you can see lots of croplands mixed with built-up areas, urban areas. So we found this strong correlation, and what I meant by land use policies is that okay, how can we encourage? How can we give a policy framework that encourages activities on the territory that are related to better well-being and lower prevalences of different diseases, including diarrhea. And also it applies to what you're showing in the housing conditions. Better housing is also related to good land use policies that are enable to place the poor in well-equipped areas, because usually the poor get pushed out because of market outcomes, right? So yes, just land use is key to not to price out the poor from well-equipped areas. Sorry, we are taking too long, I think. Sorry.
Thank you so much.
If we had more time, we could discuss, because only 2 minutes left here. So let me thank you guys. In fact, you did such a great job, and the commonality of this. Also, you three of you were talking about diseases like COVID, like diarrhea, and Xiao was talking about how to treat these diseases when she was talking about pharmacies. Really, it was really amazing to. I was not expecting to have a session that would last too long, because the previous one, when I was just half an hour. It was really interesting what we're doing here. Thank you very much once again. And we usually say here in Mozambique that Nigeria is the Chinese of Africa, because you guys are everywhere like Chinese.
Great.
According to the most recent statistics that I read, it says that in every 5 Africans, there is one Nigerian. So,
correct. Correct.
You're doing really great job there. And I had the privilege to visit Abuja 3 years ago. So it was in 2018. I was at the Academy of Science of Nigeria. So
you have to come to Lagos.
Yes.
You have to come to Lagos.
Okay. Thank you very much.
Thank you, everybody.
It's Saturday, so that's why I was not really, but I can say that was fully attended, because considering the other ones, oh my God, in a Saturday. Here is already evening, I know. Oh, sure, what time is it in China now? What time is it?
12 o'clock.
In the morning?
No, in the night.
Yes, in the night.
Yeah.
Yes. Oh my goodness.
Okay. What about you?
No, it's 15 past 6. 16 past 6. Yeah, so we're entering to the evening now.
Yes,
yeah.
It's 15 past 5 in Nigeria.
Yeah. In a Saturday. Oh my goodness. Thank you. It was really a great pleasure to
Thank
share your this session. I hope to see you one day. We never know. Once the
Hopefully.
COVID is sorting out, I believe that in the next ICCCASU, I don't know where we'll be, so we'll meet. Thank you again. Yeah.
Thank you so much.
Obrigado, Ines.
Thank you so much.
Oh,
Thank you.
obrigada.
Ciao.
Thank you all.
Thank you. Thank you.
Oh my God. My dog is greeting you guys.
Stay safe, everyone. Bye-bye.
Thank you, Victor. Catch up with you.
That you're saying goodbye, just bye.
Bye bye. Bye bye. Bye bye. Ciao. Ciao.
Bye.
Bye bye.
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 Thank you.
Thank you.
Yes,
Bye-bye.
bye-bye.
Thank you.
Yeah,
See
thank
you.
you. ICT support, technical
Yeah.
support. Bye bye.
Bye bye. See you in the next conference.
Sure.
Yes, thank you.
Thank you so
See
much.
you.
Okay, so now where are we going? To the ending section, the closing session, no?
Yes, I think we need to know from the support team, technical
Okay.
support team. Yep.
Okay,
So-
I see you there.
Yes. So you can go to the others panel session if you want, or you can sleep.
Okay.
Yeah.
Thank you.
Hey, Mr. Agimbola.
Yes.
Your presentation
Thank
was
you so
great.
much.
Yes, your presentation
Thank
was
you so
great.
much.
You're welcome.
Thank you so much. Thank you so much. That is it's due to your support too. You have been so supportive.
No, but you
I
did
want
all
to
the
appreciate you.
you did all the job. I was just moving the slide.
Thank you. Yes, you really supported it, and it turned out to be a good one. I appreciate you all round.
Thank
So,
you.
thank you so much. What's the name again? Bija or something?
Yes, Vija.
Are you on the main ICCCASU group?
Yes.
Okay. I will say hello to you later. Thank you so much.
You're welcome. Have a good day. Bye.
And you too.
Thank you.